Okay, so I would be talking to you about intraoperative complications of LASIK, because postoperative complications, of course, should be dealt by the refractive surgeons, but may fall into the domain of the cornea surgeons as well. There are no financial or proprietary interests, and you can have problems or complications during the procedure both when you are dealing with the microkeratome or with the femtosecond laser. And if you look at the LASIK complications, it can occur at all levels. It can be at the level of the flap, hinge, interface, or at the ablation depth. So the first one that I would be discussing would be the buttonhole flaps, which could be superficial or it could be deep. This is a classical horseshoe, not tear, but horseshoe shaped buttonhole flap which has occurred. And we did have a spree of buttonhole flaps because of the problem with the blade manufacturing. So important thing is that you have these marks which are pre-placed over here, the junction wallet marks. And so when you do have a buttonhole flap, one has to align it with these marks so that your flap is in the correct orientation. So this is again a buttonhole flap which is Z-shaped here, mainly because this was being done in a post-penetrating keratoplasty eye. An important thing is that the buttonhole, the epithelium of the buttonhole has to be aligned, and then you have to put a bandage contact lens over it. And in the post-operative period, one has to be careful that there can be an epithelial ingrowth here, and one has to look for it. So whenever you have a thin, irregular or buttonhole flap, you defer surgery and recut after 3 months. Alternatively, you can also do a surface procedure. Some people advocate it early because they don't want subepithelial fibrosis to occur. That would cause irregular astigmatism, and some people advocate it late so that there is refractive stability and this can be addressed. This is a case which we reported which had a buttonhole flap, which I showed you earlier, and also had epithelial ingrowth. So important thing is that one should look for epithelial ingrowth in case the buttonhole flap does occur. There can be incomplete flap which occurs because of microkeratome jamming, that is motor jamming, suction loss, drapes, lashes, loose epithelium, or precipitated salt of irrigating solution. So it is important to know where is the level at which the flap has become incomplete. If there is a tear which is there in the periphery, one can still proceed with the ablation after protecting the hinge. But if it is mid-peripheral or central, one has to reposit the flap back. Plan a recut. So if you're doing a microkeratome, then you have to plan a recut at a deeper level and have a larger flap as compared to before. So if it was say 160, it goes deeper, or if it was say 140, it goes deeper than that. And if it was 8.5, then it becomes larger than that. So this is a case where there was a torn hinge which was present, and because it was present in the periphery, one can still go ahead and do a laser ablation, put the flap back. An important thing is that in the post-operative period, at the area where the tearing is there, one has to look for the epithelial ingrowth, and also these cases have high propensity for diffuse lamellar keratitis or DLK. Then you can have a dislodged flap like this, which occurs because of squeezing or eyelid rubbing. Happens more in large, thin flaps and flaps with small hinge. And also our vitreoretina surgeons may at times cause it when they don't know that a LASIK is there and they just rub it off during the vitrectomy surgery. So management of these cases is relift the flap, clear the undersurface, reposit the flap back, allow for prolonged drying time because the flap does become edematous, and place a contact lens. Then you can have free caps. So once you have a free cap, which more often occurs in flat corneas, the cap may be lost, so you allow central epithelialization to occur, defer the surgery and wait for refractive stability. Or it is retrievable, and if the size of the free cap is greater than the optic zone, then one can again proceed with the laser, reposit the flap back and place a bandage contact lens. But if it is less than size of the optic zone, then one has to defer surgery. So this was a case in which the free cap did occur, so we went ahead with the laser ablation. Notice that there are marks which are placed in the periphery, which can be seen here. So you have to retrieve the flap from the microkeratome and then align them as it was prior to the microkeratome cut, and then you know that the alignment is proper. In this case, bandage contact lens was put, but sometimes you may have to put sutures as well. And the free cap got stuck to the underlying stromal layers. We did report outcomes of LASIK after flap complications related to microkeratoma, and we did find that in case you do address them well, the outcomes in terms of uncorrected visual acuity are not jeopardized. Then after radial keratotomy again, these segments may give away, the wedges start opening, so one has to again elevate the flap, do the laser ablation and put this flap back. In these cases, there is a chance that you might have epithelial ingrowth through the wedges of the RK flap, and then one has to be careful about it, and this is our publication on outcomes of LASIK after radial keratotomy. Then complications can occur after femtosecond LASIK as well, and I would be showing you in the videos. So you can have a opaque bubble layer, such as is seen here, and also you can have air bubbles in the anterior chamber. And because the air bubbles in the anterior chamber will not allow the laser to fire, it is best to put the tracker off and then fire, because the air bubbles do take some time to disappear. They may take a couple of hours to go away, and so it is best to put the tracker off and continue with your laser ablation, ensuring that the patient looks into the light and then the flap is put back. Then there can be a vertical gas breakthrough. That means there are black areas which have not cut. And again, when such flaps are there, it is best not to elevate the flaps, because at this point over here, it is not going to separate. So it is best to do a surgery in these cases at a later date. Now notice that here there is a black area which is present. There is opaque bubble layer as well, and the flap is being made. Now it is best to leave it like this, but if you do try to open it up, it will separate from all the areas except the area, the uncut area here, and it is best not to try to do it manually, because you may change the level of dissection. And so one can put the bandage contact lens, take this surgery at a later date. Then there can be suction break and incomplete flap, and the lamellar band treatment has been completed, no side cut, the procedure is completed immediately. But if it occurs while making the side cut, then do not lift the flap, retreat later, and this is different from the microkeratome flap. The flap has to be smaller but at a greater depth, and rarely people also do surface ablation. Then at times there can be pseudo suction. So this is a hyperopic LASIK which was planned, and there is a pseudo suction. You can see that this is just giving away and the meniscus is not forming at all. And pupil is also getting constricted after docking, which means that the suction is not built up. And then in these cases, one has to do redocking again so that the suction builds up. Then there can be suction loss, such as in this case, the suction loss was there and the surgeon still continued to make the flap. So the flap is not circular, but it is elliptical. You can see that there is a suction loss here. At this point in time, one should not have continued, but should have discontinued. So the surgery now is being planned 3 months later, and with the suction on, you do create a flap, and you can elevate this flap. Notice that this surface is not very regular after you elevate the flap, and you can ablate. It appears to be a little rough because there are two planes which are present. Of course, in terms of visual acuity, there was no difference, and the bandage contact lens was placed. But notice that there is a spindle which can be seen here, one from the previous cut and second from the cut which has been made, which does disappear over a period of time. Then you can have opaque bubble layers such as this, and this may obscure the patient target, but most cases one gets away with. So there is an opaque bubble layer which is present here. It looks as though it is impinging on the pupillary axis, but when you do ablate, it allows for ablation, and you can still get away with the laser ablation despite the fact that there is a bubble which was opaque bubble layer which was present here. Then there can be micro adhesions such as here, and this happens in thin flaps and flaps which are dry. So trying to separate this, it is not getting separated although it is cut. So best to wet this because this is a thin flap. So if you wet it a little bit and then try to separate it, it will get separated easily, and one has to be careful about the hydration of the surface as well as the flap. So to conclude, complications do occur both after microkeratome and femtosecond LASIK, but it is important to diagnose them timely, manage them appropriately, and watch other people's complications so as to know what to do when they occur with you. I would like to invite all of you on behalf of All India Ophthalmological Society, Dr. Partha Bishwas sir, who is already here, Dr. Santosh Honavar, Prashant Bavankule, who is there, to the Asia Pacific Academy of Ophthalmology, which will be held at Yashobhumi, April 3rd to 6th, 2025. And thank you very much for your kind attention.
Thank you, Dr. Thank you, Dr. Namrata, for your elaborate and the one that you said is true, that if we show it's not complication done by me, my fellow or my colleague, but the idea is to show that when I'm in a trouble at the time, how I remember that and how I come out of it. Thank you very much for your this. Any questions from the panel? Okay. I mean, it was so elaborative that there are no questions for you. Thank you. Next, we invite Dr. Prafula Maharana. Yeah, for his talk on surgical management of viral endothelitis.
So how can we let Namrata go without a question? No. I think, all the complications that she has shown over the years has been there. But again, let us assure everyone that these are absolutely rare in today's times, even though we are using microkeratomes, and there's always a way out of it. And the other thing that I think Santosh, Namrata and myself would really like to tell you, that Santosh has been very kind to extend the early bird registration for APO AIOS. Please get the early bird registration done. And it's 31st of January. Santosh, are you going to increase it even more? Santosh, no. Are you going to increase it even more? So Santosh says no to any more increase. So I think 31st of January.
So 31st is the last date. Dr. Santosh has declared that as a no extension date. And I hope to see all of you there. How many you have already registered for APO? Quite a large number. But the ones who have not, you should come. We have 120 international faculty coming from the Asia Pacific side and 100 plus international faculty from the AIOS side. So there are going to be close to almost 250 plus international faculty and of course delegates also. So I think this is the best opportunity to interact, to network, to listen to new scientific deliberations and to interact.